Sam, thank you. Thank you for that very kind introduction. And it's a real pleasure to be back again for another session. Um, so I'm going to talk about ovulation induction. Polycystic ovary syndrome is the most common anovulatory cause of infertility. And everybody is aware of the key features of this condition and the appearance of the ovaries related to anovulation. For about 60 years now, the mainstay or the primary treatment for ovulation induction in PCOS patients was clomiphene citrate. This was developed in the 60s, and at that time it was the only choice for ovulation induction. It was orally active, relatively inexpensive, and had relatively few side effects. And even when gonadotropins were introduced, clomiphene citrate still had a lot of benefits and fewer risks in terms of multiple pregnancy. So I think the widespread adoption of clomiphene citrate for ovulation induction was definitely warranted for all those decades. However, there are some problems with clomiphene citrate related to its mechanism of action. So it is a selective estrogen receptor modulator. It's a combination of two isomers. And the one that predominantly is effective in treatment is an estrogen receptor antagonist isomer, which depletes estrogen receptors in the hypothalamus and the pituitary. And that takes away essentially estrogen negative feedback on the brain. So FSH levels are increased and follicle development begins. Now, one of the problems with this mechanism of action is that the estrogen receptor depletion is not specific for the brain, it's actually generalized. So we see the same estrogen depletion occasionally happening in the endometrium or in the cervix. And as a result, sometimes the endometrium doesn't respond adequately to estrogen stimulation because the estrogen receptors are depleted. And as Professor Drakopoulos mentioned, we used to see many cases of unexplained infertility treated for up to a year with clomiphene citrate for augmenting ovulation by general practitioners or general OBGYNs before they were referred for infertility treatment. And we'd often see patients with this sort of a picture who'd been on 12 cycles of clomiphene citrate, which essentially meant they were being given a contraceptive for the whole year that they were trying to get pregnant. And this was one of the findings. Well, this specific finding was the impetus for us to develop an alternative to clomiphene citrate. And that's when we came up with the idea for an aromatase inhibitor. So one more thing about clomiphene, the isomers have quite a long half-life, up to 2 weeks. So there's depletion of estrogen receptors, takes away negative feedback of estrogen, FSH levels go up. FSH will stimulate follicle development, and the follicles will make estrogen, but the receptors remain depleted, so the brain doesn't recognize this elevated estradiol, and FSH levels remain elevated. So there is an increased risk of multiple ovulation with clomiphene citrate because of the prolonged elevation of FSH. So just to summarize the problems with clomiphene citrate, there are peripheral anti-estrogenic effects that include a thin endometrium and unfavorable cervical mucus. There are studies showing reduced uterine blood flow. All of these effects result in a lower pregnancy rate than you'd expect from the high success in terms of ovulation. And the long tissue half-life of the isomers of clomiphene results in a high multiple pregnancy rate. So we thought about using aromatase inhibitors when they were first developed for breast cancer treatment. These are drugs that prevent the conversion of androgens to estrogen in the body. letrozole and anastrozole are specific non-steroidal reversible inhibitors. They have a short half-life in comparison to clomiphene, so their half-life is around 2 days instead of 2 weeks. And they have no direct estrogenic or anti-estrogenic effects. So the way aromatase inhibitors work is they actually, instead of fooling the brain into thinking there's no estrogen, they actually inhibit the conversion of androgen to estrogen. So estrogen levels are low. The receptors in the brain are intact, but because estrogen is low, that takes away negative feedback, so FSH goes up. It will stimulate follicle development. And now when you stop the aromatase inhibitor, it wears off very quickly. Estrogen production from the follicles increases. And because the receptors are intact, they can recognize that estrogen is going up. So it shuts down FSH like it would in a normal spontaneous menstrual cycle. So usually we only get one follicle ovulating. So the aromatase inhibitors for ovulation induction have a central mechanism of action because they reduce estrogen and take away negative feedback in the brain. They also have what turns out to be a peripheral direct mechanism in the ovary to increase androgen levels, which increases FSH responsiveness by increasing FSH receptor gene expression. They don't have any adverse effects on estrogen receptors. They have a short half-life, and there is an intact central feedback loop for estrogen feedback on FSH, and that results in a predominantly monofollicular ovulation when you use letrozole by itself. There were some dose response studies showing that 5 milligrams of letrozole daily for 5 days gave a slightly higher pregnancy rate than 2.5 milligrams per day. But we also looked at the idea of using just a single dose of an aromatase inhibitor based on calculating the disappearance half-life. So if you give a 1 tablet a day, the letrozole will build up a bit in the circulation because it has a half-life of 45 hours. And then when you stop it, it disappears in a pretty predictable fashion. So we tried 10 milligrams, 20 milligrams, and 30 milligrams doses of letrozole in a single dose on day 3. And as you can see, this 30 milligram dose pretty much disappears at the same rate as the 2.5 milligram dose, but we thought using 20 milligrams, the area under the curve here is still good, is probably better than the single dose. And the letrozole actually wears off more quickly, which was an issue related to safety, especially after the paper or the abstract of Biljan came out in 2005. So we did a study comparing a 20 milligram single dose, so that's 8 tablets of clomiphene taken all at once on day 3 of the cycle, compared with 1 tablet a day for 5 days. This is the usual regimen. So here's the single dose versus the 5-day regimen. And you can see that essentially there was no difference between the two in terms of any of the parameters of the cycle, nor in the clinical pregnancy rate per cycle in patients with polycystic ovary syndrome who were having ovulation induction. And we also added the single dose versus the multiple dose to FSH, and again found no difference in clinical pregnancy rate or follicle outcome. So we believe that this is a viable option to just use 1 single dose of 8 tablets on day 3. It saves the patient having to remember to take a pill every day. And since the side effects of letrozole are idiosyncratic, they're not really dose related. The side effects really are the same whether you give a large single dose or multiple doses. So there were some studies following our initial case series, some proper randomized controlled studies comparing clomiphene citrate with aromatase inhibitors for ovulation induction. For ovulation induction, in polycystic ovary syndrome. And the major paper came from Legros and his group from the Reproductive Medicine Network. This was, I think, the first definitive manuscript published in the New England Journal of Medicine in 2014. And they looked at 750 infertile women with PCOS who were randomized to get clomiphene citrate or letrozole. And what they found was that the live birth rate for the entire group was significantly higher with letrozole compared to clomiphene. And this difference was specifically or markedly different in patients who had a BMI greater than 30, and here's the BMI greater than 39. So you can see that there's quite a separation between the clomiphene and letrozole in these two groups. There was a lower, but still significant difference in the patients who had a BMI less than 30. So the conclusion of this study was that letrozole should be considered as a first-line treatment for anovulatory infertility and PCOS. And this study was followed by this Cochrane review in 2018, looking at 9 different randomized studies, and they again found significantly improved pregnancy rate with letrozole versus clomiphene. So to summarize this part of the talk, letrozole seems to be more effective than clomiphene citrate for ovulation induction in PCOS. I didn't actually show you that data. There's a higher pregnancy and live birth rate compared to clomiphene. And letrozole may also be effective for clomiphene citrate failures. There's a low risk of multiple pregnancy when you use letrozole alone. In our hands, it's about 4%, and it has a short half-life with no anti-estrogenic or estrogenic effects. So we pretty much always see a good endometrial lining in patients treated with letrozole. So the question that remains is, are aromatase inhibitors safe for ovulation induction? And again, the seed was planted in 2005 by an abstract at the American Society of Reproductive Medicine that suggested there might be more birth defects with letrozole compared to natural conceptions. So we followed that up. My colleague and friend, Dr. Tulandi from McGill, organized a multi-center Canadian study looking at 5 clinics in Canada who had experience using both letrozole and clomiphene citrate. And we followed the outcome of 911 pregnancies. 514 babies were born following letrozole or letrozole plus FSH, and 397 babies were born following clomiphene citrate or clomiphene citrate plus FSH. And we looked at congenital anomalies in these 2 groups. So what we found was that the overall malformation rate was double in the clomiphene group compared to the letrozole group, but this was not significant. We didn't have enough cases. Major malformation rate was 3% in the clomiphene group and 1.2% in the letrozole group. Again, this was not significant. But when we look specifically at cardiac anomalies, which occur about 1 in every 400 pregnancies in the general population, we found that there was only 1 cardiac anomaly out of 514 births in the letrozole group, but 7 out of about 400 pregnancies in the clomiphene group, which was significantly different. So in conclusion, letrozole for ovulation induction doesn't seem to be associated with an increased risk of birth defects when compared to clomiphene citrate. And on the contrary, we found that clomiphene may be associated with an increased risk of cardiac anomalies. And this sort of fits with that 2-week half-life, because for a drug to be cleared completely from the body, it usually takes 5 half-lives. So that would be 10 weeks in the case of clomiphene citrate. So it means that there may still be some clomiphene citrate around when the baby's organs are forming. Finally, I want to show you this meta-analysis that was presented at the American Society of Reproductive Medicine meeting last year. They looked at 4,613 babies from 44 studies with the use of letrozole. 2% of the babies were born with congenital anomalies, and 0.5% of the babies had major congenital anomalies, and this was not different from natural conceptions. So in conclusion, we now believe that aromatase inhibitors should be a first-line treatment for ovulation induction in patients with PCOS. The efficacy for ovulation induction is similar to Clomiphene. Letrozole may be efficacious in clomiphene citrate failures. We don't see any adverse estrogen receptor effects, so we don't see thin lining or poor cervical mucus with letrozole, which may explain a slightly improved pregnancy rate. There's a short half-life and no accumulation from cycle to cycle. And there's a very low multiple pregnancy rate in patients with polycystic ovary syndrome, usually around 4 or 5%. That translates then into a reduced need for monitoring, which I think is important if you have general OBGYNs or general practitioners doing ovulation induction without easy access to ultrasound monitoring. The newer data indicates that aromatase inhibitors are safe with no adverse fetal effects when used for ovulation, assuming that a pregnancy test is negative before the letrozole is started in a patient who's amenorrheic. So thank you very much for your attention, and I look forward to any questions that you might have, Hassan, or anyone else.
Thank you very much, Professor Casper, for an excellent presentation from the father of letrozole, of course. I have a lot of questions, and I will start with this. A case report of 10 follicles with letrozole administration. How can you explain this?
Well, that happens. There was a case of triplets reported too, or actually maybe a sextuplet case reported with letrozole. And I think just because you're using letrozole doesn't obviate the need for follicular monitoring with ultrasound. So I think it's important to see how a patient responds to letrozole. And I think most of the time it'll be one follicle, but occasionally you'll see multiple follicles develop.
Is the pregnancy rate the same with letrozole versus gonadotropin in ovulation induction in PCO and IOI? The results of gonadotropin versus letrozole.
Yeah, I think the results, the pregnancy rate is slightly higher with gonadotropins, but the multiple pregnancy rate is very much higher.
Thin endometrium with letrozole?
Yeah, I think it's not a result of letrozole. If there's a thin endometrium in a letrozole cycle, it's probably a patient who has thin endometrium to start with.
Can you elaborate more on the single dose?
Yeah, so as I said, we sort of calculated the single dose based on the disappearance half-life of letrozole. And we now give the patients the option to take either 8 tablets all at once on day 3, or to take 1 or 2 tablets daily for 5 days. And our results are essentially identical using either treatment. So I think it's totally safe. The higher dose doesn't lead to higher risk of side effects. And it's very convenient just to do 1 dose and not have to think about it for the other, for another 4 days.
Is there letrozole resistance like Clomiphene resistance?
Yes. So I think patients who have very high AMH levels, very high androgen levels, may also have resistance to letrozole as well as Clomiphene.
Extended letrozole treatment for more than 5 days?
Yeah, I think people have been trying all sorts of things, step-up regimens and extended treatment. I think extended treatment makes sense in patients who don't respond to a 5-day course. So it may work in some patients. Dr. Mitwali, I know, is very fond of the step-up protocol where you increase the dose on a daily basis for patients who don't respond normally.
I think the vote is ready for your comment, Professor Casper. So we have the response to your questions. Can we have the poll, Akram? Thank you very much. Professor Casper, you can go on, please.
Okay, so clomiphene citrate is most commonly used oral agent. Possible side effects include all of the following, except increased cervical mucus. That's right. So most people got that one. All of the following effects are important with anastrozole and letrozole use, except long half-life. So the majority of patients got that correct as well. Aromatase inhibitors may improve ovarian response to gonadotropins in poor responders. The mechanism of this possible action is a decrease in intraovarian androgens, an increase in intraovarian androgens, a decrease in intraovarian estrogens, an increase in intraovarian estrogens, or a decrease in IGF-1. So it's actually, this is pretty interesting how split this is, but the right answer is that because letrozole blocks conversion of androgens to estrogen, there's an increased level of intraovarian androgens with letrozole, which increases FSH receptor gene expression, so that would improve ovarian response to gonadotropin. And what is the preferred order of treatment? So this is based on a brand new paper that just came out from Rob Norman's group in Australia. So what they found was that the best order of treatment in patients who may not respond initially to the first drug is letrozole, because letrozole should be the first line treatment. If they don't respond to letrozole, you try letrozole plus metformin. And if that doesn't work, then go to gonadotropins. I'm surprised. I thought most people would pick clomiphene, letrozole, and if that didn't work, gonadotropins, and then laser ovarian drilling. But I think the right answer is this based on Rob Norman's paper. Okay, thank you.
Thank you very much, dear Professor Casper, for an excellent presentation and comments, and for being with us and always supportive. Thank you very, very much.
My pleasure.
Thank you.